Sinus rhythm with resting heart rate less than 60 beats per minute in adults or below the normal range for age in children is called the sinus bradycardia. Normal heart rates in children are: in newborn it is 110 to 150 beats per minute. At 2 years it is 85 to 125 beats per minute. At 4 years it is 75 to 115 beats per minute. And 6 years onwards it is 60 to 100 beats per minute. There are various conditions which leads to sinus bradycardia. These are physiological response in absence of heart disease, pathological response in absence of heart disease, and pathological response in presence of heart disease. And some drugs also causes bradycardia. Physiological response in absence of heart disease are during normal sleep, high level of physical fitness, increased vagal activity, and hypothermia. Pathological response in absence of heart disease are obstructive sleep apnea, increased intracranial pressure, hypothyroidism, hypoxemia, reflex response to hypertension. Pathological response in presence of heart disease are sick sinus syndrome, some familial conditions like the pacemaker ion channel mutation, and acute myocardial ischemia or infarction. Some situation leads to sinus bradycardia. This might be due to the administration of certain drugs. These are opioid, especially the fentanyl, sufentanil, beta-adrenergic blocker, calcium channel blocker, Anticholinesterases, and alpha-2 agonists like the clonidine and dexmedetomidine. This may also seen in case of vagal stimulation like the traction on the eye, traction on the peritoneum, pneumoperitoneum, Laryngoscopy and intubation, and bladder catheterization. Other conditions that leads to sinus bradycardia are baroreceptor reflex during the hypertensive episode, during spinal or epidural anesthesia, especially where the cardiac accelerator fibers, that is the T1 to T4, are get blocked. Electroconvulsive therapy, and in the patient with acute myocardial ischemia or infarction. How can we prevent this type of situation? We can premeditate the patient who has the risk for vagal response with an anticholinergic agent like the atropine or glycopyrrolate IM. Atropine can be given as the 0.4 mg and the glycopyrrolate is 0.2 mg IM in adults. During spinal or epidural anesthesia, bradycardia should be treated aggressively and as early as possible with atropine IV bolus 0.4 to 0.6 mg, as it can progress rapidly to cardiac arrest without warning. Vagal response due to the traction on the peritoneum or the extraocular muscle or pressure on the carotid sinus are not always avoidable. In this situation, surgeon must be informed regarding the bradycardia and ask him or her to release the pressure or the traction. If needed, the condition should be treated with atropine or the glycopyrrolate IV, and the procedure should be carried with caution. If same response again occur, then they repeat the sequence if necessary. For prevention of sinus bradycardia, normal plasma electrolytes level should be maintained in all the patients. Electrolyte abnormalities like the hyperkalemia and hypermagnesemia causes the bradycardia. Bradycardia may be well tolerated, particularly if it develops slowly. Acute onset bradycardia is more likely to be symptomatic. What are the manifestations? These are slow heart rate that can be observed by the ECG, pulse oximeter, arterial line, or the palpation of the peripheral pulses. Other manifestations are hypotension, junctional or idioventricular escape beats. In the conscious patient, we can get the nausea, vomiting, or mental status changes. There are some conditions which may mimic the sinus bradycardia. That might be due to the monitor artifact, like the failure of the monitor to count the QRS or the pulse oximeter signal, ECG lead disconnection or the failure, oximeter probe displacement or the failure. There might be drop beats that's seen in the second degree AV heart block, Mobis type 1 or type 2. Third degree AV block, pacemaker malfunction or the failure, like the lead fracture, lead disconnection, inappropriate settings like the output too low or sensitivity is too high. Management. First of all, we have to verify the bradycardia and assess its hemodynamic significance, checking monitor for heart rate, blood pressure, pulse oximeter, palpate a peripheral pulse. Scan the surgical field for the operative cause as discussed previously. If in response to surgical stimulus, alert the surgeon to stop the precipitating stimulus. Notify the surgeon of the bradycardia. If the bradycardia is associated with the severe symptoms like the profound hypotension, loss of consciousness, seizures, then remove the possible cause immediately. Ensure adequate oxygenation and ventilation. Delivered 100% of oxygen. Turn off all the volatile anesthetics. Management of the airway is very much important. Patient may require intubation. Bradycardia is common in prolonged hypoxemia. If the condition is remaining same or worsening, then call for help. Treat with atropine 0.4 to 0.6 mg IV. Repeat every 3 to 5 minutes to total dose of 3 mg. Dopamine IV infusion should be started 2 to 10 microgram per kg per minute. Epinephrine IV 10 microgram bolus. Repeat with escalating dose as necessary. If bradycardia fails to resolve quickly with epinephrine bolus, initiate cardiac pacing, either transcutaneous or transvenous. Newer defibrillator typically offers the pacing function. If the patient is awake, then proper analgesia and sedation should be done. Transvenous cardiac pacing is effective but logically difficult in emergency conditions. Sometimes CPR may also needed. If bradycardia is associated with the mild to moderate symptoms like the moderate decrease in blood pressure, nausea, vomiting, or mild alteration in the sensorium, ephedrine IV 5 to 10 mg increments, repeat as necessary. Atropine IV 0.4 mg, repeat as necessary. Glycopyrrolate IV 0.2 mg, repeat as necessary. If bradycardia is not associated with any obvious physiological consequences, then monitor the patient closely. What are the complications of sinus bradycardia? Escape arrhythmias, complications of pacemaker, tachyarrhythmias and hypertension secondary to drug treatment, and cardiac arrest.